Yeah, at the outset, let me thank Dr. Saxena for his invitation, and it's really a privilege to present in this forum. So he requested me to talk about regarding macular surgery. So there are a lot of sorry. Uh, we have a lot of macular disorders to deal with, basically surgical disorder. But this talk, I'm just restricting myself to basically vitreomacular interface, and not touching the other disorders. So we'll go ahead with the various indications for macular surgery, which includes vitreomacular traction, macular hole, epiretinal membrane, foveoschisis, optic with maculopathy. Sorry for this spelling mistake. Vitreoretinal traction, secondary to diabetic and other vascular disorder, and then you have another subset of submacular surgeries, totally different. So which obviously I won't be touching today in this talk. So looking at a strong attachment of vitreous, where we have physiologically at vitreous base, then optic nerve, you have macula and major retinal vessels. And pathologically, vitreous is firmly adherent to the chorioretinal scars, lattice degeneration, meridional complexes, and cystic retinal tubes. This is the strongest attachment, obviously, is at vitreous base, followed by optic base margin. So posterior vitreous detachment generally progresses slowly over months or years, as against previously thought of that it is an acute onset. Generally, it doesn't happen that. It begins typically at a perifoveal area, spreading gradually throughout entire perimacular area, and then near complete separation of posterior hyaloid face, except at the disc, and the stage 4 would be vitreopapillary separation, which we all appreciate during fundus evaluation as a Weiss ring. So the balance between static and dynamic tractional effects of perifoveal vitreous detachment can cause all these like vitreoretinal disorders, which we are trying to deal with today, is like idiopathic epiretinal membranes, macular microholes, idiopathic macular holes, fractional CMEs, classic VMT syndrome, fractional diabetic macular edema, and myopic macular retinoschisis. So when you look at the perifoveal PVD, when it is a small vitreous adhesion somewhere near 500 micron or less, it imparts a greater tractional stress per unit retinal surface than when you have a larger vitreoretinal adhesion. So it has its significance because when a traction is in a smaller area, traction is much more per unit. So you land up in a problems like macular hole or localized cystoid foveal thickening. As against when you have a broad adhesion, probably overall stress is low. So macular dehiscence is unlikely, and so it causes diffuse thickening or tractional detachment, and also get exacerbation of the conditions like AMD, ERM, and diabetic macular edema. OCT is an invaluable tool now to understand all these pathoanatomies. I'm not going to go in detail, basically looking at the International Vitreomacular Traction Study Group, grossly divided vitreomacular traction as a vitreomacular adhesion, vitreomacular traction, and full thickness macular hole. We deal with one by one. So vitreomacular adhesion is basically perifoveal detachment, but normal foveal control. There is no tug or pull on the foveal area. You have an elevation of the cortical vitreous above the retinal surface, but patients generally are asymptomatic, and usually it leads to spontaneous resolution over a period of time. It can be again grossly divided depending on area involved as a focal when it is less than 1500 micron, or it can be a broad when area is broader than 1500 micron. Coming to vitreomacular traction, so basically when you have a macular attachment of the vitreous is within the 3 millimeter radius of the fovea, which leads to distortion of foveal surface, cause sometimes intraretinal pseudocysts and elevation of the fovea above the RPE. But usually there is no full thickness interruption of all retinal layers. Again, it is broad if it is more than 1500 micron, or we call it as a focal when it is less than 1500 micron. So again, it has its implication whether it's having a macular schisis or CME or having vascular leakage or forming the pseudocyst, depending on the area of traction involved. So this is few variations. We call it as a V shape when you have a like a posterior hyaloid is separated on either all the sides except at the macular area. On J shape when a temporal part is separated, but nasal part of posterior hyaloid is still adherent. The importance of it is that the V pattern has relatively better prognosis than the J pattern. These are again just few images like the different type of fractional component based OCT patterns you see when you look at these patients, when you study, including few patients can have even sensory retinal detachment and vitreoschisis as well. Clinically, typically, when you examine the fundus, generally there is a distortion of fovea, blunted foveal reflex, or you can have a cystic changes, and occasionally you can see subretinal fluid, which again you can pick up clinically as well as on OCT examination imaging. The term coined as a tractional CME basically is a subtle variation of vitreomacular traction syndrome, where you have a limited partial PVD, or rather what you call as a vitreofoveal traction, not vitreomacular traction. So you have an increased foveal thickness, can have a cystic changes, but typically leakage is absent on fluorescent angiography, which typically helps us to differentiate it from when you're talking about tractional diabetic maculopathy. So these eyes can have spontaneous resolution occasionally and better anatomical and functional outcome eventually. So when you look at a natural course of the VMT, 53% of eyes generally can have spontaneous and complete separation of posterior hyaloid face with a resolution of signs and symptoms of traction with improvement in a visual acuity. And look at here, this is one of the case looking at a 73-year-old male. 2013, we saw him right eye having a vision of 615 N8, showing a point attachment of the posterior hyaloid over a period. It's a traction has increased, vision has dropped to 618 with having some cystic changes in a macula. We suggested surgery, however, because of some personal reason, patient decided against the surgery. And when he came back, subsequent follow-up in 2016 and 15 and 16, as you say, until August 2016, subsequently, a posterior hyaloid has spontaneously separated. The cystic spaces are resolved, and you see a normal contour has restored back. Patient is maintaining 6/9 and 6 vision. This is another patient, 70-year-old male. Vision was 6/5 and 6, and you can see a focal traction July 2013. Because vision was good 6/9 and 10, we decided to observe this eye but have a close follow-up, and over the next 2 years again posterior hyaloid separated on its own, vision is back to 6/5 and 6. Therefore the difference, like previous both the cases, foveal contour has restored, but now look at this case as a 38-year-old female reported with a metamorphosis since 2 months. Vision was 6/6 and 6, but you can see both the eyes, you have a vitreomacular traction, the splitting is there, and cystic places are there, but vision was good, so we decided to have a very close follow-up, and with subsequent follow-up over next 5 years, vision is maintained 6/6 and 6. There is no posterior hyaloid separation. Subtle worsening of the OCT images, as you see, I have seen, but over 5 years, because vision is maintained, we are safely, this type of patient can be observed. This is another case, similar way, over 3 years. If you see same pattern, maintain 89-year-old male, vision is also maintained at 6/12 and 8 over last 3 years, but hardly any change in a foveal OCT pattern. So these cases can safely observe if you have a better initial vision, if there is no change in the visual symptoms, and if there is no worsening on sequential OCT. Of course, this patient need regular vision check, surrogate monitoring, and sequential OCT. But then when we should intervene? When there is a documented loss of vision, when there is a worsening of metamorphosis, when there is a progression of traction on a sequential OCT, or there is a large size vitreomacular adhesion, or ERM, or both, which unlikely has resolve on its own. So when you look at, so sorry. So goal of the treatment here is to relieve the traction. So what are the treatment options here? Either medical option treatment, which in the form of plasmin, but actually almost initially there are a lot of buzz about it, but almost it is people have given up now because of there are other lot of other issues. Pneumatic vitreolysis can be attempted, but most of the time we resort to the surgical option to relieve this traction. So yes, I'm skipping this slide because pneumatic vitreolysis basically can be suggested when there is low VR OCT interface reflectivity, when the overall diameter is less than 500 micron, and when you have less extensive vitreomacular traction. So probably these eyes you can attempt injecting the gas bubble, and that act of injection itself sometimes separate the posterior highlight and the traction may relieve. However, most of these eyes eventually need surgical intervention, and typically what we do is a 3-port pass vana vitrectomy, separation of posterior hyaloid, and if removal of the epiretinal proliferation, if their ILM peel is a little bit controversial here, and obviously we use a different dyes there. So this is one of the case, having a use a tricot as a dye to separate the posterior hyaloid. You have to ensure the posterior hyaloid is completely separated. You start usually on a nasal side because sometimes because there is a tug on the fovea, as you see the OCT picture, if you try to pull on the nasal temporal side of the disc, you can land up sometime inducing macular hole on the table. So separate the nasal side first, and then as you keep on inducing PVD, keep on cutting around, and then come on a temporal side gradually. Quite sometime it comes out on its own. So initial vision was 618 N8, and over last 9 years follow-up patient last reported for a follow-up on 2018 when she was maintaining 6.6 N6 vision in this eye. It's important to identify vitreous crisis in this eye sometime, because if you feel with a primary, when you do a vitreous, when you tricot, you remove the vitreous and you think everything has come out, but it makes sense sometime to repeat injection of the tricot, look for additional attachment. And as this one of this case, if you see, even though we induce the PVD and then we put a tricot again, it is sticking there. So we know something is there. And see again, the entire sheet is coming up here once again. So this is typically vitreous crisis as you are seeing here. Of course, intraoperative OCT can also be helpful, but may not be available in every center. But yes, that can be one of the tool to assess the like a residual posterior cortex in this type of eyes. So this is a 39-year-old male, has a last DOV for 6 months. Right eye vision was 6.6 N6, left eye 624 N10, and that was he has a basically symptoms in the left eye, as you see foveal traction there, probably partly almost full thickness hole there. And when you look at it after vitrectomy, the foveal contour has to some extent restore back with the vision recovering back to 612 N8, but because of some distortion is there, and as you see foveal area is not that healthy, vision is not gone back to normal. So this is another case, 76-year-old male, right eye, having a tug around, again a similar picture, almost like a previous slide, 612 N10 vision, but here because of impending full thickness macular hole, and when you try to peel it up membrane, this eye, when come back for a 6 weeks follow, you have a, though fovea is restoring back, vision has come back to 6.9 and 6, but probably this defect may remain as it is. However, sometime over a period of few months, it can again settle down. And as what happened, you see that subsequent case here, 76-year-old male, typical again, same picture. Here because the way amount of fovea is pulled up on cystic changes, we were worried about creating full thickness macular hole on table during vitrectomy and separating the posterior hyaloid. So we decided to do a fovea sparing ILM peeling along with the removal of the vitreous and posterior hyaloid and ERM, and gave enough time. Slowly things started settling down, and it took almost 9 months for this macular area to settle back. But patient does have some amount of, you see the RPE practically not there, ISOS junction is gone. So in fact, pre-surgery vision, which was 618, is maintaining now 624 and 6. But sometimes that's we have to accept in a situation. So coming to other causes of tractional CME, like diabetic CME, myopic tractional maculopathy, neovascular AMD, and this pathological PVD sometimes can exacerbate primary clinical features. And coming to tractional diabetic CME, when you look at it, basically because of associated with restriction and what we sometimes can call up like a diabetic vitreomaculopathy. So typically when you see, generally they are associated features of diabetic retinopathy, usually have incomplete PVD associated vitreoskisis as OCT by picture you see with a dot attached posterior hyaloid and some amount of vitreoskisis as well, and CME is also there. Sometimes we have visible fibrous membrane and FFA shows leak with other features of diabetic retinopathy or DME. So this is one of this case having a, and you, if you observe clinically, I'm not sure how clear the video is, but you can see the glistening posterior hyaloid which is stuck there shining while doing vitrectomy. The key here is to induce the PVD. Again, you see this in between this glistening thing, and you have to meticulously try and induce PVD, again starting on a nasal side, trying to pull all around gently. This was a little bit older case. I did not use tricot for this case, but view was reasonably clear. Now, the patient had a few isolated, small isolated proliferation NVEs, and when you pulling this up, we have a spot like some tiny bleeders over the surface of the retina. And this is the way posterior highlight slowly coming up. And once we started, we gradually separated it over the macular area. And then once we remove this posterior hyaloid, we again try to reconfirm. And now I injected tricot to recheck whether we are dealing with a vitreoskisis as well. OCT definitely is helpful in these eyes for detection of vitreomacular components, schisis, perifoveal PVD. You can see these various pictures. I am showing like a steep macular edema, multiple attachments of the posterior hyaloid, and even sensory detachment, and even the last case, the last right side lower corner, you see them how badly macula is distorted, and generally these eyes can have reasonably bad prognosis. So looking at a DME, also there's a possibility is there that spontaneous vitreofoveal separation can occur and sometimes lead to resolution of DME. So conventional medical treatment generally does not work where we try about steroid or anti-VEGF or laser. Generally, it's like a macular edema is resistant to these treatment options, and that's why eventually we need to intervene surgically in these eyes. So vitrectomy, separation of posterior hyaloid with or without IM filling generally help to reduce the foveal thickness and improve the symptoms. So this is another case where this patient had a ERM as well and associated sensory detachment. You can see the video center, there is some elevation. You see the opaque retina. So this was an old 20 gauge video which I used long back. I operated. So ERM is separated using the spatula, and then I use a tricot after separation of posterior hyaloid. This is tricot being used to peel the ILM in this case. So before we started using these our vital dyes, and this is what used to be standard method. You can, Dr. Sandeep probably will recognize these old forceps we used to use to peel the ILM in these eyes. It comes out quite well, but forceps is reasonably big, so you have to go a little bit carefully, slowly, because there's always a possibility of you are hitting forceps, particularly back of the forceps, touching the retina somewhere else, and that's the way whole ILM came up, and that's the end of the surgery here. So this is a 68-year-old female, diabetic of 15 years, right eye, NPDR with tractional DME, and underwent vitrectomy, laser with the cataract surgery. And once posterior hyaloid is separated, foveal contour has reversed back and vision improved from 636 to 67.5. Another case, 56-year-old female, laser PDR. You have tractional DME with left eye was treated with anti-VEGF, but right eye underwent surgery. What you see in a right eye You have a vision 660, multiple layers of the posterior hyaloid. Though over a period of time, fovea settles down, there is a thinning, lamellar hole-like pattern, but sensory detachment settled down and vision improved from 660 to 69 over 7 months. So generally, this patient take long time to settle down. Another patient with a 64-year-old male, 20 years of diabetes, distortion of vision in the left eye, 6 months. Basically, this is a very peculiar case. This patient had macular hole when he reported to us, full thickness macular hole in the left eye, lamellar hole in the right eye. We did a surgery. In fact, first surgery was for macular hole closure. Patient got back 6 and 6 vision over 6 weeks, but subsequently came back with a 6, again lost a drop in a vision in the left eye. Now patient had a DME, was treated with anti-VEGF, and after 3 injection, 8-month follow-up shows that edema is resolved. So typically, again, it raises the question whether is ILM peeling really protective in a DME, because here post ILM peeling, patient developed a DME. Right eye eventually again subsequently progressed to full thickness macular. These are again cases, both eyes, one patient after DME, after vitrectomy, macular edema resolves. There is a thinning of the macula, but vision improved in both eyes. And this is another case having a extensive exudation in the foveal area. Vision was 360, and post vitrectomy, though thinning is there, exudates are resolved over a period of time. Vision did improve to 645. That brings us coming back to now myopic macular fractional maculopathy. So it's generally seen in a high myop eyes, typically anteroposterior traction with relative stiffness of the inner retina and relatively non-distensible ILM with the inner retinal blood vessels. This all lead to eventually foveal schisis and detachment with or without lamellar or full thickness macular hole. And when you look at a natural course, again, this is a typical eye, 2011, typical myopic maculopathy. Vision was 675 and 6. So we decided to observe over a period of next 4 years. If you see here, vision is still maintained 6.9 and 6. Skies is more or less stable. So safely these eyes can be watched. This is another case, having a look at the 4-year skies here, 2018 and 2020 or 2 years. There's a spontaneous resolution of the chisis cavity. So when to intervene? Again, when there is a progressive decrease in the vision, when there is a progressive worsening of the OCT, if you have a foveal detachment, if you have full thickness macular hole or associated retinal detachment. So this is one patient, again having a 2017, if you see, look at the picture, over a period of time, over 2 years, there is a progressive worsening of the foveal schisis on OCT. So probably this is an indication for the surgery. So another case you see here, and looking at the pattern over the next 3 years, OCT pattern more or less looks similar except subtle changes over 3 years, but definitely there is a progressive drop in a vision. And then that's why it's an indication for the surgery. So now what we should do, how you choose? There are 2 options. We have either vitrectomy or macular buccal. If you have a shallow staphylloma or there is no staphylloma at all, along with lamellar or full thickness macular hole or an foveal schisis, probably vitrectomy with ILM peeling is the option. But if staphylloma is large enough and you have a foveal schisis but no underlying detachment, primary macular buccal can be tried. But if you have a posterior pole detachment along with fractional maculopathy, probably these eyes need buccal and combined with vitrectomy. Both the options are acceptable. And this is one of the patients where there was no macular hole, sensory detachment along with attraction, and we did beat ILM peeling. And over a period of time, over almost a year or so, macular detachment settled down. Though there is again foveal thinning is there, this typically, as you see in a myopic eyes, there is an underlying atrophy, but vision did improve from 636 to 615 and 6. This is a 67-year-old female, left eye, progressive visual loss over last 3 months, underwent again with plus ILM peeling, and as you see here, vision gradually improved over 3 years. It took actually like from 645 gradually improving, and regular follow-up sensory detachment remains almost for a year, and then slowly 3 years everything settled down. Patient is maintaining 6, 9, and 6 vision. As against now, this is one other patient where you have 54-year-old female, loss of vision noticed 12 days back. But what you look at here in OCT, there's a large stapyloma. Again, these are early days we operated. We were not sure about buccal or vitrectomy. So, but macular hole, I was not sure, though this OCT shows some subtle discontinuity. Decided to go ahead with a vitrectomy alone, though retina settled well, but because of large stapyloma, there is a gap. It is sort of type 2 closure of the macular hole. Vision did not improve. And probably this will be one of the cases ideally should be combined macular buccal and vitrectomy would have tried. So coming brings us that this is just a video showing how the macular buccal we do. Basically temporal, usually open 360-degree conjunctival peritomy. We use Maureen Davis T-shaped buccal. So the macular plate, as you see, goes under the fovea, and it pushed under the lateral rectus, and the two arms of the T, then so that is settled plate under the fovea and two arms under, then pushed under the inferior rectus and superior rectus. And you generally we use a chandelier, or you can use indirect ophthalmoscopy to check the position of the macular plate. When it's this is where you can see that it is settled well under and supporting the foveal area, macular area, and then the two arms of the T can be sutured on either side of the medial rectus, pulling and assessing and judging the traction. So this is one of the patient with the pre-op fundus picture montage, and what you see is OCT big huge indent is because of macular buccal. Over a period of time, this buccal height reduces, fovea settles down, and this was post-op picture of that patient. Coming to vitrectomy, basically with the advent of newer instrument technology, past-point vitrectomy has become now treatment of choice, but case to case you can deal with, and your experience will tell us when you should do a buccal or you can combine along with it. Generally, we prefer 20 or 23 gauge because of these eyes are having a large axial length, and 25 or 27 sometimes you may not be able to reach the posterior pole. So you need to make sclerotomy is relatively posterior. You need a longer instruments. So if you have available because longer forceps, you are available now. ILM peeling forceps or end gripping forceps is there. Also, there is difficulty focusing through the wide angle system where more vertical angle of the instrument is needed. So you keep on bumping against the instrument. So also relatively lower magnification with your wide angle system. So probably contact lens system is better, which gives a much higher magnification, and then you don't keep on bumping against your tree. And this is one of the patient. What we need to look at here, what I'm trying to show you, again, typically these myopic eyes have a multiple layers of vitreous. This is, I'm inducing PVD with the IVT. You can see the whole posterior highlight is separated now from the disc. I removed this highlight, chewed it up, clear everything. And once they clear, I could see the foveal fold as you see in a few minutes. I decided to put BBG, but BBG did not stain the ILM at all. And then I thought something is not right. So I decided to go back again the second time, IVTA injected. And what you see is again, now another layer. As you see, the second layer is coming on. Only suction was enough to get my second layer out. And with the previous experience, subsequently again, even though this layer came out, we decided to inject one more time IVTA, and that's where we got another third layer as well. So these myopic eyes are usually have more than one layer of vitreous, and so look for a schisis before you attempt ILM peeling. So yes, ILM peeling, most of the eyes we prefer to do now because it improves the retinal compliance and also ensures complete removal of vitreous and cellular debris and collagen component, and thus the retina settle much well, become a compliant. Yes, there are difficulties again when you peel this ILM, as you see here, because globe is large, so it is difficult to reach the posterior pole sometime, and that's why you need a longer forceps. underlying RP choroid atrophy at posterior pole, so there is compromised contrast, so visibility can be an issue. And if scapuloma is too deep, the steep angle, so angle for to peel the membrane can be an issue. And sometimes the attachments are so firm, you run the risk of creating iatrogenic retinal breaks. So fortunately, this ILM and staining also sometimes may not be that good enough to give a good visibility, and that's what we could peel the ILM. This is a case showing both combined vitrectomy and the buccal pre-op OCT, as you see and fundus photograph. 6 weeks post-op, sensory detachment is still there. We followed this patient over a period of time, 2 months, the sensory detachments reduced, and over 5 months, macula is flat now. So, but yes, there is sort of lamellar hole-like configuration is there. So, like not all the cases need to be injected gas. If there is no macular hole or there is no break, there is no need to inject the gas. We can leave it as it is, and most of the time it settles on its death. Coming to epimacular membranes, basically is a fibrocellular proliferation at the VR interface. Etiology can be varied, and variable symptom patient can be asymptomatic even to severe metamorphopsia and the vision loss. And surgery is indicated when the patient is symptomatic, when there is documented vision loss, or when there is associated other surgical indications. Anyway, you're going inside the eye, you want to remove the membrane. This is just how we should do. When sometimes you are lucky enough that you can have a age, you can very easily see. This is one video is a 20 gauge, basically another one. Typically, you have there was a visible age, so separation was easier. So once you lift that edge, you can use your forceps to just grasp the edge of the membrane and then start peeling it off. So technically, surgery is relatively easy in these eyes. So, however, that is not the case in all the cases. And if you can't see the edge properly, probably then you use any sharp instrument. Here, one place I use needle, other side MVR blade, and once you got the edge, then we have tried to stain it. Also, we have tricot or brilliant blue or even trypan blue, old days we used to use. And once you create that edge, and then go ahead peeling this membrane fully. And most of the time, visible membrane is less than when you start peeling, you realize extent is going quite peripheral. Now, this is the case. Patient had a vitrectomy, RR, EL, SOI, and when they came back, silicone oil removal, and then had a thick ERM. So again, decided to remove that ERM along with silicone oil removal. What we need to do is, when you start peeling and created the edge, you just don't hold at one edge and just keep on pulling. You lift the membrane, pull little bit, again release, again re-grasp it, again go near the retinal surface as you see, and when you stretch it, you can see the edge where it is, how far it is extending. Release that one, go back, pick up that edge, lift this up, pull little bit more, again release this, again go back, and now you see again the extent is going far peripheral, so release that one and grasp here. So go slowly all around. Your movements are always tangential to the retina, so you do not induce rather minimize the risk of creating retinal breaks. There are a few hemorrhages as you see there as the membrane separates fully. So this is the picture pre-OCT, pre-op and post-op 2 months macular contour has restored in these eyes. Whether we should peel the ILM in all ERM cases, yes, there is no clear evidence. Personally, I do not recommend ILM peeling, but yes, a lot of people, they prefer to peel the ILM. Each one has their individual option. But if a part of ILM has already come out while peeling ARM, then probably I would complete that, but not otherwise. But certain cases where you have cystic fovea, you have also underlying full thickness macular hole, or inflammatory, post-inflammatory ARM, probably ILM should be removed. And here are 2 cases. One is uveitic case, and the other one, when I was removing this thick membrane, it just happened part of ILM came, and when we stain it, as you see in a few seconds, you will see here, put and you see those bits and pieces of ILM are left, part of ILM is already gone, then obviously it makes sense to go ahead and peel this membrane off. So it is said that almost 7 to 8% of cases there is a possibility of recurrence of ERM, and if you remove ILM, probably recurrence, that is the possibility incidence can be minimized. This is just to show the fundus picture, post-scleral buckling ERM. This is another indication, and post-ERM removal fundus picture. So coming to the last entity, I'm just closing after this, the macular hole. It is a full thickness defect in a fovea central. Typically on a slit lamp biomicroscopy, you see a round excavation with a well-defined border with the interrupting beam of the slit lamp and overlying semi-translucent tissue or pseudo-operculum, what you can see. And there is sometimes a cup of subepiretinal fluid. The vision depends on the size, location, and the stage of the macular hole. And patients generally complain difficulty in near vision and metamorphopsia. And sometimes in advanced stage, there can be obvious scotoma. This is just a typical classification in macular hole. Stage 0, where the no macular hole, only vitreomacular adhesion is there. Stage 1A and B basically is occult hole, which you can pick up on OCT, or you can see the yellow ring around. And 3, 4, 5, 2, 3, 4 are a full thickness macular hole, depending on size and whether presence of PVD or not. OCT staging also has been done. 1B typically stage show is a partial opening. Stage 3 is a operculated macular hole, and stage 4 is complete PVD. So stage 1 holes are generally have a good visual acuity and can usually resolve occasionally. But stage 2 and above macular hole, generally they need a pass-pana vitrectomy along with leaving it open, or you can have ILM-free flap covering the macular hole, or inverse flap or multi-layer flap. People have tried lens capsule, amniotic membrane, or even the retinal graft. And internal tamponade obviously is given in most of these eyes, followed with the prone position, variable duration from 3 days to 3 weeks. So this is one of the case. Typically, usually you can start on a temporal side most of the time, but wherever you feel the edge is, you can able to grasp it. I prefer pinch with the forceps directly and start peeling. Of course, we use a BBC and BBG, but before that, you have to ensure that posterior hyaloid, a complete vitrectomy is done most of these cases. And this is what and how much to peel. Generally, we try to go up to arcade. If a hole is smaller, generally even lesser, you can peel a little bit smaller, where some 1.5 this diameter also is okay. And this is a picture showing the same eye. The hole has closed now with a vision improving to 612 and 8. This another eye now having a larger macular hole. So you can have tried now what we are doing is either inverse flap most of the time, or where you can have a pedicle graft rotation flap, or typically what we did here is separate the ILM from all around. Excess ILM was removed, and keeping this ILM over the macula, just multi-layer flap over the fovea. Somehow I am not comfortable with a free ILM flap or even trying retinal graft directly somehow, because I somehow not yet convinced as far as when a functional outcome is concerned, though people have tried. So this excess flap is chewed up, and then this flap is rolled over. You can put even if a drop of viscoelastic if you want to keep those fold flap over the macula. But once you do fluid air exchange, it's covers over it. Don't stuff in a hole, just cover the macular area, and that's the end of the surgery. And so this is 61-year-old female where we did with ILM peel, inverse flap, and on OCT you can see this flap is, though hole is closed, vision has improved to 6/9 and 6, but you can see OCT nicely that flap is hanging, floating freely there. So how much importance it has, I do not know. This is a case where recalcitrant failed macular hole surgery, and we decided to go back again. And as you see, the extra whatever additional peeling was done here. Initially it was just 1.5 days this diameter around, and now we decide to go ahead up to the arcade. As you see, another layer, extended layer, we just taking out the ILM here. Technically surgery is not difficult, but if you already peel the ILM up to the arcade, then you sometimes do not have a choice what to go on. Probably those are the eyes people you want to try macular rotational retinal graft or free graft. And this is what extended ILM peeling in this eye. Post-trauma, again, you can have macular hole. Typically, these are young patients, and why I'm showing this video typically is what is important here is most of the time PVD is not present, and you need to put an extra effort to induce PVD, because unless you remove the posterior highlight, surgery is not going to be successful, and you will not be able to reach the posterior like ILM in these eyes. So, with meticulous PVD induction is important in these eyes. You have some difficulties when macular hole in a detachment. So first, this video, if you see, you try to peel this up and you have difficulty because there is no counter traction. So in these eyes, probably what ideally you should be doing is not fully starting temporally in peeling towards the disc. Instead of that, you see the second video. Now, what happened? You start from the disc where disc act as a fulcrum and peel the membrane towards the periphery from the disc, and then job is relatively easier as you see this video. So I think I'll stop here just to summarize. In macular tractional disorders, spontaneous resolution is reported. Surgery should be advised only when there is a documented worsening. OCT is useful to understand the pathoanatomy and also to assess the disease progression. Initial posterior highlight phase separation should be attempted on a nasal side of the disc to minimize the risk of iatrogenic macular hole. And as there is a vitreoskisis is frequent, so repeated tricot staining helps us to ensure complete posterior highlight separation. You can use a sharp instrument to create the edge while peeling, create the edge for ARM removal, and then grasp ARM close to the retina and peel tangentially to minimize the risk of iatrogenic breaks. Vital dyes gives us better visibility and hence more complete dissection and better final outcome. In high myopes, vitrectomy or buccal can be planned depending on case to case. If there is no break, there is no need to give a tamponade. Routine ILM peeling is not generally needed except in macular hole eyes. And most of these eyes have a prolonged recovery time, so you need to counsel the patient well in advance. So otherwise, they can be disappointment. I acknowledge my fellow Dr. Akshat Kothari for helping me collecting data about this presentation, and thank everyone for patient hearing. Thank you very much.